Welcome to the Her Health Podcast, transforming health for women and girls at risk, where we empower women and girls to take charge of their health and well-being. Join us as we shine a spotlight on issues affecting women and girls' health and explore ways to create positive change. Get ready to be inspired and empowered as we discuss health, advocacy, and empowerment for women and girls at risk. Please be advised that this podcast may cover sensitive topics such as gendered violence. We understand that these discussions can be difficult to listen to. If you feel uncomfortable or need support, we encourage you to prioritize your well-being. Consider exploring our other podcasts if these topics are triggering for you. Resources can be found in the description.
Hello, everyone, and welcome to the Alliance Against Violence and Adversities, or AVA's webinar series, which we call Webinar Wednesdays because we aim to have a webinar every single Wednesday. I'm your host, Dr. Sarah Yursich. With AVA, I'm an early career researcher and lead on the webinar series. Outside of my role with AVA, I'm the co-director of the Frida Center for Research on Violence Against Women and Children and faculty in Sociology and Criminology at Capilano University. Just a couple of procedural things before we begin. This webinar is being recorded, which is great because you can revisit the recording at any time. It will be up on AVA's YouTube channel. You can also share the content today with anyone you might think would benefit from it, colleagues, friends, family. Throughout the presentation, we encourage you to ask questions. So please use the Q&A function to pose any questions that you have for our speaker, and we will make time at the end of the presentation to answer all of your questions with Femi. Before we begin, I want to acknowledge that on a national level, we encourage all Canadians and visitors to Canada to learn about the Indigenous peoples of the lands on which they live, work, or visit, and become engaged allies together. We, as Canadians, in the spirit of truth and reconciliation, respect the self-determinations of First Nations, Métis, and Inuit peoples, and their rights and responsibilities in cultures, languages, and the pursuit of wellness. Before I hand over to our speaker today, I just wanted to let you know that the focus of today's webinar is sexual violence and trauma-informed care, which will be explored through a public health approach. And we are joined with Femi Akinsanya from Calgary Communities Against Sexual Abuse, or CASA. If you would like to learn more about the work from CASA, this is actually the fourth in a series of webinars we've done with them, so please go ahead and revisit the other content. And now, Femi, thank you so much for joining us today, and I'll hand it over to you.
Thank you, Sarah, and good afternoon, everyone. And hello to everybody from wherever you're joining us for today's webinar. So I'm going to do a quick introduction. My name is Femi Akinsanya. I am the co-director of the Training, Resource, and Education Center at Calgary Communities Against Sexual Abuse, which is otherwise known as CCASA. We are the primary sexual violence agency in Calgary and surrounding areas, providing a myriad of services, including clinical services and education services. So a little bit about me. So my 9 to 5, as I say, is as the co-director at the Training, Resource, and Education Center. So that is our training and education program that provides lifespan education and training, and also outreach and community engagement and community development. My educational background is in psychology and also health sciences. And also I sit on the City of Calgary subcommittee, their Gender Equity and Diversity subcommittee, and I'm also the chair of their intercommittee subcommittee as well, working to improve the lives of Calgarians on a municipal level. I'm also a speaker. I contribute to various research projects. I've contributed to research at the University of Calgary and also at the University of Alberta. So that is a little bit about me. Like Sarah said, the focus of today's segment will be on trauma-informed care. So we're really looking at the intersection of trauma-informed care, sexual violence, but also phrasing it in a public health approach and perspective, really centralizing what is sexual violence, what is trauma-informed care, and how do we have wraparound services and cohesive services, and really being able to mobilize it for the overall wellness and well-being of everybody we serve from a healthcare and social care and human services perspective. So the learning objectives for today is to first be able to define trauma-informed care. So we're going to give you the definitions, but not only the definitions, we're going to talk about a little bit about the application. So I don't know what you all do or where you all are joining us from, but there's a little bit of things you can take that you can adapt to your own professional lives and your own workplace and the people you serve, whether they are patients, clients, or community members. Next is we're going to name the 5 principles of trauma-informed care. Next, again, moving into the application of trauma-informed care is how to create a trauma-informed environment. So we're going to look at the spaces you operate in, and again, the different pieces you can adapt to your work environment to make sure it is rooted in trauma-informed care. We're going to name key 5 messages of support for the session. And the next half of the presentation is that we're going to talk about burnout, secondary/vicarious trauma, empathic state strain, and low impact debriefing. So we're going to turn the lens inward, look at you as an individual, as a service provider, as a helping professional, to know what you need to be able to provide the best care for the people you serve. Next is we're going to name some strategies for preventing and managing burnout. And lastly, we're going to talk about CASA. Who are we? What do we do? Our services, and very important information, the referral process to get clients or you as a professional in touch with CASA for your needs. So today's topics includes the sexual violence umbrella. So we're going to talk about what is sexual violence. Unfortunately, for today, we don't have enough time to get into all the nitty-gritty details, but we're going to give you necessary information that you can use to apply to the principles of trauma-informed care and that public health approach. Next is language. So this is a little bit more on the application of trauma-informed care and some skill building you can apply to your professional lives. So how do you talk to clients or patients that have disclosed sexual violence? And this is even transferable to your personal lives, the people you love, your network of supports, your communities. How do you use language to empower people who are disclosing sexual violence and their experience of sexual violence trauma? Next is we're going to talk about the trauma-informed care model. So again, we're going to go deep into it. What is it? How do you apply it? And what can you take from it? Next is the socio-ecological, sorry, a little bit of a typo, model. So this is a framework, actually it's a public health framework on describing the impacts and the transfers of different things. So we're going to loop this into a sexual violence context for you to understand the scope and the why behind why we need trauma-informed care, why these different skill sets are important, and how you can make change and impact on various levels. Next is supporting from a trauma-informed care perspective. Again, giving you that practical skills, allowing you to transfer this to your client or patient interaction. Next is taking care of yourselves and taking care of others. And we're going to wrap up today with CASA services. All right. So firstly, we're going to define sexual violence. Again, we don't have enough time in this session today to go into all the details, but this is a good way to visualize the concept of sexual violence. Usually, we see sexual violence in usually a couple ways. Sexual assault, maybe a little bit of sexual harassment, maybe we even see child sexual abuse in like the conversations of pedophilia or molestations. But we want you all to have an expansive definition of what sexual violence is. And it can be all of that I've listed and more. So as we see sexual violence as of now, we have child sexual abuse, sexual assault or rape, sexual harassment, stalking, indecent exposure, degrading sexual images, voyeurism, cyber harassment, intimate partner sexual violence, sexual exploitation, and trafficking. So again, we've just expanded the scope of what sexual violence can be. And this is important from a lot of perspective, from policy development, education and training, advocacy, and also patient and client support to have a more broader definition of sexual violence and what it can be and how it can manifest and the potential impacts of sexual violence. And another thing I want to add, and this is also just my personal things I loll over, is that this is how we see sexual violence now in 2025 in this current moment. We have a whole new emerging landscape of technology and AI that we really are just learning and knowing as it's happening. So potentially this can even expand to more things that in this current moment in time we can conceptualize and we can visualize, but the impacts are there and the support skills and the approaches are still going to be pretty much similar. So again, with all of these definitions and different aspects of sexual violence, a lot of the support skills, the approaches are similar. The big differences between the different ones is like who's involved in it. So, for example, with cyber harassment, it could be, the Calgary Police Services cyber forensics teams can be looped in. Intimate partner violence, that's an intersection with domestic violence. So, this is a coordinated response between a domestic violence organization and a sexual violence organization. Trafficking, we have great organizations, especially in Alberta, that deal with human trafficking and the experiences and the impacts and the advocacy around that. So again, the impacts are quite broad, and there are different organizations that deal with these things and institutions and systems that deal with these things on various levels. But the biggest thing, especially going back to the concept of trauma-informed care and that public health approach, is having a coordinated response. So at CASA, we might be dealing with the mostly with sexual assault, child sexual abuse, sexual harassment. That's more so our mandate, our scope, but we also prioritize having coordinated responses with other institutions, Alberta Health Services, Calgary Police, the Calgary Police, RCMP, Alberta Justice, and other community partners and other organizations that might deal with domestic violence or human trafficking. So again, we want to reduce silos and promote coordinated response. And for those who don't work in social services and human services organizations that deal with very one specific aspect of sexual violence, we want to empower you to have those skills to, again, work with these organizations, know what to do with yourself, your organization, your capacity, your responsibility, your professional scope, and also how to resource out appropriately. So again, when do I give CASA call? When do I give an organization like Fear is Not Love a call? So we really want to give you those skills to know, okay, this goes here, this goes there, and also in-house what you do with your patients and your clients, be empowered to deal with it, in a doctor's office or at a newcomers organization, wherever you serve your clients and your patients. Right. This next slide is we're talking about language. So one of the first ways you interact with anybody is through language, whether it's a simple, hey, how are you? My name is Femi, or you're having a deep conversation, getting someone ready to be referred to another organization. We interact with people usually first through language. So language matters. Language is where you set the tone and ground that interaction with the patients, the clients, or a loved one. So we really want to centralize language and let people know language matters. What you say and what you don't say, it's quite powerful, especially during initial disclosure or any disclosure of sexual violence. So we have different words and different colors across the screen. So let me pick out some word. So we see the one in teal or blue or green, however you see that color, victim and survivor. This is language we often use really quite casually, and these words mean something. So in the legal system, a victim has a very specific meaning, a very specific purpose, and serves a role in the legal process. So so does the words like survivor, maybe not so much legally, but colloquially, how we talk about people and their experiences. But what we like to encourage and what grounds us here at CASA is empowerment and choice, having people be able to choose what comes next. And in choice is also choosing how they define themselves, right? And their experience. So one thing we say is that we listen first. So active listening is always first, and listen to how someone self-defines. Do they call themselves a victim? Do they call themselves a survivor? Or are they saying, I'm just me, I'm just this person that has experienced this thing? So however they self-define, we hear it and then we mirror that language back. So if that person says, I see myself as a victim, or in the conversation of disclosure, they start using victim language, language, we would then mirror that language back. If they say survivor, we would then mirror that language back. So we want to first start out with a very neutral language. So the neutral language is a person that has been harmed, a person that has experienced sexual violence. Very neutral. And we do that so we allow that person to define themselves, how they self-identify with that experience of sexual violence, and define their experience. So defining their experience is not labeling things as rape or child sexual abuse or molestation. Keep it quite neutral. I like to personally use harm, right? Because even sometimes saying sexual violence to someone that is disclosing, especially for the first time, can be a little bit jarring. So, oh, that harm that you experience. Sometimes some people say that thing, and even if they say that thing, and that thing is quite abstract, it's quite broad, they're not really naming something pointedly, we reflect that back. So yeah, so as a responder, I would be like, oh yeah, so you know, that thing that happened to you, what's coming up for you? What do you need next? How can I support you best? So mirroring that language back and not imposing the language of rape or sexual assault or sexual harassment. So this allows them to be in the driver's seat of their experience. So at any point in the disclosure, they might change the language and say, you know, I was raped. So then we would then mirror that language back because they have given us permission to use that language by how they have identified themselves and their experience. Another one that is very tricky for people to get a grasp of first, but is quite important, is how to define the person who has harmed them. So commonly we use the words like perpetrator, quite legal language, offender, legal language, but that person can also be a parent, a relative, a partner, a coach, a religious leader. And they may never change the language of how they identify the person that's harmed them. They still might, in the disclosure, by say, oh, that is my, you know, my best friend. And they might never say that was the perpetrator, that's offender, even though, you know, it's well-meaning for most of us to say, you know, that person harmed you. Of course, that person's an offender. Of course, that person's a perpetrator. We want to keep them in that driver's seat. So we would then mirror that language back. So yeah, so that thing that your best friend did to you, what's coming from up for you? How does that make you feel? What do you need from that? How can I support you through this process? A statistic we know is, and this statistic comes from Alberta Association of Sexual Assault Centers. So that's our provincial organization, our provincial network. They did a 2019 prevalence study in Alberta, and then they found that 87% of sexual assault, the person who harms the person who has experienced sexual assault is known to that person. So that really combats the myth of stranger danger. So that's also why using neutral language first and then mirroring the language back that the person that is disclosing is using in that disclosure experience is quite important, because 87% of the time they have some kind of trust, rapport, and prior relationship with the person who has used sexual violence to harm them. So again, complications, feelings, layers upon layers upon layers, they're unpacking, you're receiving information, but we again want to empower them, put them in that driver's seat. And oftentimes I say, as a professional, I'm often not in the passenger seat of the disclosures. I'm not even in the back seat. Sometimes I may be even in the trunk, but most times I'm just a pit stop on their healing journey, right? I'm just a place they stop to get gas, to get snacks, maybe pump their tires, and it's usually a one-off interaction. I would most likely never see them again. But even with that one-off interaction, it's quite important. It's quite fundamental. So imagine going down a highway, your gas is going to empty, and that gas station in the middle of the highway, in the middle of nowhere, has no gas, right? That is quite impactful for the rest of that journey, right? Even though it's one stop, it's one moment, you will never go back to that gas station again, it can really impact the trajectory of that person's healing journey. Again, we're not the driver of it, but that pit stop can really change where that goes and what happens next for that individual. So again, to summarize this slide, language matters. So first, we start off with a neutral stance, a neutral response. And this is neutral in language and not in emotion or reactivity, but neutral in language. So a person that has experienced sexual violence, a person that has experienced harm, the person that has harmed you, the person that did that thing to you, if that's how they define it. we then mirror that language back. And upon mirroring that language, we then reflect that language they use to describe themselves, their experience, and the person or the people who have done the harm to them. So this next slide, we're going to actually dive into trauma-informed care and the principles. So this is an amazing, I'm biased toward this video. I think it really encapsulates the emotions and the importance and even the urgency around trauma-informed care. So this video is by Advancing Trauma-Informed Care, and this is a national initiative from the States, or United States, made possible through the support of Robert Wood Johnson Foundation, and is produced by Freshfly. So we'll begin to watch the video and we'll come back and debrief a little bit after the video.
How can you ask someone about their body? How can you ask somebody about their mind and not recognize their experiences in the world as they're living in that body, as they're thinking and having that mind? It really is about recognizing people as whole beings and not just body parts. To me, that's trauma-informed care.
The majority of illnesses and conditions that people are treating in primary care settings are trauma related.
There are things going on inside that you cannot visibly see, that if you don't ask about, it's maybe a barrier to the actual care that the healthcare system wants to provide.
We want to give people good care, but we want them to thrive, not just be healthy, but thrive. And it's very hard to thrive in this community. I experienced patients that were behaving in ways that were really stressful, cursing, yelling, really heightened emotions at the front desk, in my office, breakdowns. We might naturally ask ourselves, what is wrong with that person? Trauma-informed care is really about saying, what happened? Why would a person behave that way? I think one of the biggest frustrations that I've seen from my medical colleagues is frustration. Like, oh my gosh, I keep telling this patient the same thing over and over again. How many times are they going to come in, not listen to what I recommend, and then have the same symptoms and then keep coming back for the same symptoms? If we ignore trauma in our practices, what we're going to end up doing is doing the same work over and over again without having a different outcome.
I mean, our experience as providers has changed from being overwhelmed, from having a chaotic clinic, to an experience where we're feeling like we are doing the absolutely best job possible.
People come willingly. They're using more services. So they're understanding that their health is not just that medical service, but it's what they eat, how much you move, and the state of your soul.
What we've seen is people kind of having longer periods of stability, and maybe they slip, but they get back in touch with us more quickly than they used to.
Once you start communicating where you're not being dictated to, someone is actually asking you, how do you feel about this? And how, it builds that trust. It's like, wow, they actually heard me, and I see it.
Talking about and becoming trauma-informed does not have to be a traumatic experience.
This change process is incremental, and you can begin this as an individual person in your clinic and make a meaningful difference, not only to your patients, but to you as a practitioner. It's not radical to think that our job as primary care providers and why we went into primary care in all of our different disciplines is to actually help patients heal. I mean, that's not radical at all. It's self-evident, but it's like taught out of us. And what we're doing now in this movement towards trauma-informed primary care is to teach that back in, is to help people realize that their vision for why they went into this to begin with is to help people heal and to connect with them in that process, and to heal themselves in that process, and to have joy in that process.
So that video perfectly encapsulates the soul. I like to say the soul of trauma-informed care because it is such a holistic approach to patient care, advocacy, system navigation. It really goes beyond, again, what they said, body parts, right? Or charts or patient history. It's more robust, it's deeper, and it brings together things that are seen, especially in a, very much a clinical setting, and that are unseen in a clinical setting is their day to day, is, what does their nutrition look like? Even beyond nutrition, do they have access to food? What is the housing? Did they commute there 40 minutes in -40 in Calgary by transit to get to the doctor's office, or drive 15 minutes in a warm, comfortable car to get to that doctor's office? Those little things that are seen and unseen can really be transformative in how we visualize trauma-informed care. Even going to things that are unseen, especially in the role of sexual violence, we're talking about things like collective trauma, intergenerational trauma, racial trauma, trauma from just being in a healthcare setting, right? Have they, maybe the last time they were at a hospital, they were watching a loved one go through cancer treatments, and that's what's destabilizing them. So again, we see people's facial language, maybe some aggressiveness, or maybe they're distant or they're not communicative, but maybe it's more than what is actually being presented in that office today. Is things that go back, months, weeks, even generations, that impact them. So it's good to ground ourselves as service providers in trauma-informed care. And again, it is a holistic approach. It brings together a lot of things that are seen and unseen, things that are spoken and things that are remain silent. So again, this is why trauma-informed care is fundamental. Honestly, it should be a requirement in how we provide services, not just in healthcare or social and human services, but all type of helping professions. Whether you're a teacher, an EMT, a firefighter, police officer, a judge. Again, it goes beyond the scope of healthcare, and it really brings everything together for the help and the benefit of the patients, clients, and communities we serve. Yeah, okay. So this is the socio-ecological model. So this is a public health model that we have adapted to a sexual violence approach. Everything is still consistent. Every way you envision it, every way you visualize it is still consistent. But imagine how this plays out for someone who has experienced sexual violence. So we have on the bottom an individual, their knowledge, their skills, and their attitude. So for example, if you're in a doctor's office or a clinic, that's what you're seeing. You're seeing the individual. You're seeing, what do they know about their family history, their attitude. Are they, communicative? Are they open? Are they approachable? Are they all these things? And then their skills to be able to, navigate a healthcare setting, their skills to be able to, do their own self-assessment of their own healthcare needs, their skills to understand, the language of healthcare, the language of medicine, that whole arena, the language of nursing. So you see that, but there's more happening. So we go up to the interpersonal. So things, maybe they might come with a family member, so you can get more exposure to that, but oftentimes we don't see all these things, but interpersonal. So we have their families, their friends, their social networks, and social networks are also in person, the people they see every single day, the people that their flesh and skin, they're real people, and also their social networks are online as well. We have so many different platforms that really do consume a lot of people's lives, especially in certain generations. So we can never remove how that person experiences life, and we can never extrapolate the social and the digital aspects from it. So social is in person and also online. Organizational, so we have organizations, social institutions. So this is organizations you belong to as a professional, and social institutions that you belong to as a professional. Also on a patient level, what the social institutions and organizations they're interacting with. So an organization, is CASA, a social institution is the healthcare system, AHS, to put it broadly, or Recovery Alberta, to put it quite broadly. Next is community, relationships between organizations. So this is how we build, we break down silos. So how are we communicating? And sometimes the communications are on a very high level. So there are, partnership agreements. Like for example, at CASA, we have partnerships agreements with Alberta Health Services, or the Calgary Police Services. So they're very much, in paper, written. There's a formalized process. And relationship can also be more so less informal. I mean, and when I say less informal, I mean like less paper. There's not a contract where, very important people sign at the bottom and say, this is how we're going to navigate a relationship. Another way of relationship building is you as a professional calling CASA for professional consultation. Maybe you are a nurse and then you had an interaction, or you have a patient and you don't quite know how to navigate, or if the best resources, or even want to debrief. That's another way of relationship building and building relationships across organizations. So there's the formalized ones where we have partnerships, we have agreements, we have ways we're going to navigate systems and referrals, and this patient can come here, all of that great stuff. And then there's the more informal way of relationship building between organizations through individuals, professionals using other organizations as resources, referring patients and clients out appropriately, etc. And lastly, on the biggest level that impacts all of us, whether, we like it or not, our public policy, national, provincial, municipal, local laws, all of those things, right? Again, this impacts all of us, whether we are the patient or the service provider. So again, this is things that we can do on our day-to-day personal basis. Is how we advocate, right? Things like voting, being an informed voter, an informed citizen, knowing that this bill is coming, it's about to go into place. How is this going to affect how I do my job, how I'm able to serve, patients and clients, all of these kind of things. So these are all the ways we can look at the issue of sexual violence. We have it from an individual perspective, how, individual we see the topic of sexual violence, individually how a patient or a client is presenting the impacts of sexual violence. Then we have interpersonal, organizational, community, and public policy. They are all important, and they're all happening at once. So it's bottom up, top down. Everybody wants to know which one is it. It's all happening at once. That symmetry, that synchronousness, it's all informing each other, right? There's almost a perfect flow into it. So there needs to be conversations, advocacy, and education and training on all levels. So that's to plug CASA as well. That's, as an organization, we address sexual violence on all levels, from individual level. So that's individual counseling, our SART teams, police and court support, to interpersonal. So we have group counseling options available, counseling options available for loved ones of people who have been impacted by sexual violence, organizational. So our relationships with different organizations and social institutions, our agreements, how us as professionals navigate information and referrals through that organizational stance. And then we have our community, and also we have our public policy. So through our organization, our provincial network like ASAS, we are making sure that sexual violence remains an important topic for our lawmakers, our public policy holders, our the public officials, the people that make the laws, and allocate the funds. We make sure that is an important, it stays on their radar, and make sure that sexual assault centers are adequately funded, seen, and we can, keep running so we can provide the essential services in the community. So here we're going to explore the principles of trauma-informed care. So sometimes you see trauma-informed care stated as 5 principles. Right here, there is 6 principles. But again, we're going down to the soul of it all, the essence of it all. And I like to say that trauma-informed care is a philosophy, is an action. There are definitely actionable steps you do in trauma-informed care, but it is rooted first in your philosophy, your individual philosophy, your philosophy as a person outside of what you do for work, and especially your philosophy as a health provider, a service provider. How do you see the work that you do, and what is that rooted in? And that impacts how you see your patients and how you approach your patients. So, the first step of trauma-informed care is safety. So, creating a physically and emotionally safe environment is essential. This involves ensuring individuals feel secure, respected, and free from the risk of re-traumatization. It includes clear boundaries, transparency in procedures, and establishment of supportive atmosphere. So again, we are now creating safety. Safety is in the physical, safety is in the emotional, safety is in the psychological. And then one thing I want to say is we want to reduce the risk of re-traumatization. Their triggers are a very funny thing in the sense that it could be any or anything, come from anywhere at anywhere at any time. So there's no way you can say exactly, exactly every one of those patients or clients triggers because they probably can't even list perfectly exactly what their traumas and triggers are. But we're doing things with intention. We're going in with the headspace that, okay, triggers and traumas can happen in the space, whether in the physical sense, whether it's in the emotional and psychological sense. So it's just going in with the mindset that this thing is possible. It's not impossible to happen. So again, it's coming in with that readiness and that preparedness and the intentionality of creating safety within what is possible in your professional environments. Again, we're going to talk about it a little bit later. There are certain kind of, ways we can create a safe environment that's not feasible in a doctor's office for a lot of reasons. But again, is having that intention and checking in when you see these things bubbling up for your patients or your clients. Next is trustworthiness and transparency. So, building trust with individuals who have experienced trauma is crucial. Healthcare providers should be reliable, consistent, and honest with their interactions. Transparency in treatment plans, decision making, and sharing relevant information can foster trust. So, as much as just communicating, like, again, the plan, the processes, you might not have, hours and days and all that kind of stuff. Most time, if you go to your general practitioner, they'll give you what, 15 to 20 minutes. But again, in that 15 to 20 minutes, can you strategize how you can make these things, transparency, decision-making process, and sharing relevant information a top priority, the priority of the interaction, so that again, the patient is in that driver's seat and they're fully aware and they're fully informed in the process of what's going to happen next and what is happening right now. This is a good way into peer support. So again, leaning on your peers, we're going to talk about what is this called? We're going to talk about low impact debriefing, burnout, all of that kind of stuff a little bit later. So that'll bring in peer support quite nicely. But we're going to jump into choice and collaboration. So, trauma-informed care acknowledges the importance of empowering individuals to have a voice and choice in their care. Collaboration between healthcare providers and patient promotes a sense of control, autonomy, and mutual respect, including the patient in decision-making processes and honoring their preferences is vital. And I'm going to echo honoring their preferences is vital. I'm going to say it again, honoring their preferences is vital. Even though as a very knowledgeable and a very skilled professional, this is what it looks like, evidence-based medicine, what is most likely going to happen if you do this treatment or you don't do this treatment. You have the technical knowledge. But again, that patient has the ability to change their preference, to change the decision, even though it may not make sense to you. Going back to that previous videos, there's things that are unseen that is not in their patient history, that can't be documented cleanly in a patient history notes. Things that are around collective trauma, intergenerational trauma, even how they got to the doctor's office or how they got to the the hospital or any kind of office or clinic, right? Those are those invisible things that are moving why that patient may respond in a certain way, even though you may not have the time to really unpack that, or they may never want to disclose that. Just know maybe that's a factor in their decision-making process. But no matter what it is, whether they say it or they don't say it, or you can see or you can't see it, we have to honor their preferences in decision-making processes. And, it's good to verbalize that I'm going to honor what you choose for yourself at this time because you know yourself best. Again, not to take away from your professional judgment and your expertise, but this is a way to enhance it and bring the patient in and call them in and again, promote holistic wellness. Next is empowerment and resilience. So empowerment, voice, and choice. So we said in so many ways already, trauma-informed care recognizes and nurtures the strength and the resilience of individuals who have experienced trauma. If it focuses on fostering their sense of self-efficacy and supporting their recovery journey, empowering individuals to make positive changes and rebuild their lives is a core aspect. So people who have experienced trauma are resilient. Even though their load may be heavy, it's a lot to carry. There's so much resilience in humanity, in the human spirit for generations since the dawn of time. So we have to honor that person is resilient. They know what's best. You might know what is best in terms of books and procedures, and you've been doing this for years, but they know they know their lived experiences, the intersections that we do and do not see. So again, we need to honor that they are resilient and they have the ability to make the best choice for themselves. And lastly, is cultural sensitivity, cultural, historic, and gender issues. So trauma-informed care is sensitive to and respects the culture, social, and diversity aspects of an individual's experience. It recognizes that trauma and its effects can be influenced by cultural factor, promotes cultural responsive care that respects and addresses the unique needs of individuals from diverse backgrounds. Again, the things that are unseen, or a lot of these things can be seen, right? But again, we have to know that intersects to why they might choose certain ways. They say, okay, I want to call CASA, or I do want to call CASA, right? I want to make a formal report. I don't want to make a formal report. This is all can be informed by their cultural lens and their lived experiences and their marginalization and compounding effects of intersectionality, especially for folks who are marginalized or experience subjugation in many different ways. So the biggest thing is this all comes together to frame and understand impacts of trauma. Impacts of trauma is really what mobilizes why we do a trauma-informed care approach. And I always like to say, so when you ground yourself as a service provider in trauma-informed care, it really does make your work easier in the sense of it makes it smoother, right? It can make it a smoother interaction and a more positive interaction on more ends. This is a muscle you have to build, especially if you've been doing it so long and you really haven't found a way to um, interweave in trauma-informed care into your practice. It might be a little bit foreign at first, but when you find your stride, your step, and the way you're going to impose trauma-informed care that is authentic to you and the scope of your work, it really does make for a smoother interaction and keeps impacts at the forefront and the impacts of trauma central and how you can best support patients and clients and community members. All right. So again, to summarize, the 5 principles of trauma-informed care includes awareness. So awareness of the trauma on the person that has been harmed, survivor, victim, however they choose to identify themselves. Remember that language matters. Second is safety for survivors in a physical and emotional level. Next is trustworthiness in the process and the relationship. And trustworthiness is built through transparency, informed consent, and disclosing processes and next steps. Sometimes you have to disclose sometimes your thought process. Like as a healthcare provider, how did you arrive to know that this treatment plan is the best or might be the best approach for this ailment? So again, trustworthiness is built in communication and transparency and also accountability. Next is empowerment in decision-making process. So they are the driver's seats, right? How do I, as the service provider, keep the patient, keep the client, keep the community member in the driver's seat of this interaction? And lastly is inclusiveness for all, really putting the intersectionality as a hallmark part of that anybody's identity, especially a patient and client when they're presenting in a healthcare or social care, human care setting. So here are some tangible steps that you folks can integrate into your practice. So one is greet patients with warmth. And you might not be the first person in that doctor's office or that office building organization, most times people have some form of receptionist. So trauma-informed care starts when that first door is open, whether it's in a receptionist or whoever, an admin staff that's at the front. That's where that interaction starts. That's where you start building the foundation. That's where we start walking through the process. So this is something that's great to have conversations with your entire team or your entire organization, even though they might not be the one providing the health care, they're not the frontline care, they're not providing the medical intervention. They are also involved and quite critical in the trauma-informed context. So, for example, if there's a receptionist that is dismissive, that is cold, that is not asking integral question in a compassionate way, that can really derail the process or the sentiments of the patients by the time they get to you, maybe as a nurse or a doctor, whoever you are providing the direct care for that patient. So greet with patience and warmth, and that includes the people who are greeting them at the very front door. Next is be patient and understanding. I'm a strong believer the world needs a little bit more patience and definitely more understanding. So yeah, it might take them a while, a very quote unquote simple question to you, but it might be a lot to unpack for them. Like another common one is like, oh, family history. Does you have a family history of heart disease? It should be like, oh, yes or no. It should be quite a simple question. But for them, maybe it's the first time someone's asked, or they really have to think about it. It wasn't discussed in their family. It's quite taboo. They don't even know what heart disease is. So be patient and understanding in the process of them talking. They're warming up, they're thawing, they're getting to know you. Going to the doctor is not like going to Disneyland. It's going to a healthcare provider, unless it's a massage. Unless it's a massage, is not usually one of, we're skipping to do it. So be patient and understanding that this is not where most people want to be if they don't have to be here. Next is understanding the signs and symptoms of sexual violence. So, unfortunately, in this presentation, due to time constraints, we don't have time to go through it thoroughly, but there are a myriad of signs. So, it could present as anxiety, depression. They could be dysregulated, right? They could just break down and not be able to hold it together. They can be sensitive to touches in certain places. And when we say certain places, it's not just places below the neck. It could also be the mouth as well. We did a really great session with Alberta College of Dentists, and we really talked about dentistry and sexual violence and how, again, orally, there can be a lot of sexual violence that happens, and the impacts of that. Being restrained is another thing. So, or like not having enough information or all that kind of stuff. So the signs and symptoms of sexual violence is quite vast, and I encourage you to connect with CCASA, connect with our Trek team to see more robust trainings you can do so we can really go in depth for the various signs and symptoms and how sexual violence manifests. Next is respect the patient's boundaries and body space. So again, body language is so important. I say strive to be on eye level or be equal in level. So don't stand above somebody. Be mindful of the space between somebody. So obviously don't come super close. Don't be weirdly distances as well, like on the other side of the room. Maybe like 2 to 3 feet is usually like a respectable space to be in someone that you're actively communicating with. And yeah, just be mindful of that. Ask them, where do you want to sit? Do you want to sit on the chair? Do you want to sit on the bed? So allow them to determine where they feel positionally most safe in that interaction. Again, wherever that is feasible and where that makes the most sense. In obviously a lot of healthcare settings, you can't have there's not a lot of options in where you can position your body as a patient, but it's always good to ask if there is a way you can accommodate them in that way. Next is be aware of potential triggers. So for example, if someone is doing a pap smear, that's something that's top of mind for a lot of folks. But even like going back to the example about dentistry, we never really correlate, getting just a regular cleaning with your hygienist as a potential trigger for sexual violence. But be aware that basically any and everywhere is possible, right? there is no one way that sexual violence just exists. So have a more expansive definition of what sexual violence is, going back to the umbrella of sexual violence, and just know that triggers can be anything from the way the light hits somebody, or a sound, or seeing a certain kind of medical instrument, or just being in the healthcare setting can bring back trauma and triggers. So be aware for that, and also be equipped with things like grounding techniques and de-escalation techniques to help that patient if they are triggered in that moment. Next is provide clear information, and clear information in layman's terms. A lot of people are not well versed in the language of healthcare, and it's fine. They're not supposed to be. They didn't go to nursing school. They didn't go to medical school. They did not, they're not a public health professional. It's not their job to know, all the language of healthcare, but it's the job of the healthcare provider to provide the information and the support in language that they can understand. So really know the power of layman's terms and being able to communicate clearly in a way that people can understand language. And another thing about providing clear information is also understanding like literacy. We strive to in our public and community approach have language as understood for people that don't have reading comprehension or language scale beyond like a sixth grade level. So again, that's something to keep in mind, and this is something that impacts more people that we want to admit that they don't have the language ability that is so robust that we a lot of professionals do have. And that could be because they are newcomers, English is a second language, or any other reason that, their language skills can be more stifled. So yeah, something to keep in mind. Next is use the trauma-informed care principles. Next is respect your ethical codes, ethical bodies, your colleges, any kind of professional thing that grounds you and keeps you having your license. Please respect that, refer to that. That is very important. Next is collaborate with other professionals. This is where CCASA comes in. We love to do professional consultations. We really want to, again, deconstruct those silos, reduce the silos, and foster collaboration amongst interdisciplinary professionals and teams, because we recognize that we're most likely not going to get the first sexual violence disclosure. They're more likely to disclose sexual violence first to their general practitioner, to a nurse they're working to, an EMT, a dentist, a hygienist, a social worker at a newcomers organization, even a professor, before they're going to get to CASA. So we're usually not the first line of people or professional people that get that first disclosure. So that's why it's important for you to, expand your professional network, work with other sectors. So again, we can have that holistic approach. We're breaking silos, we're fostering collaboration, and we're keeping trauma-informed care central. And we're recognizing that we all have a role to play in sexual violence support, even though some professions do it more directly and more poignantly than others. No matter what, we all have a role to play. Next is engage in continuing education and training like you're doing today. So this is a great platform. I love AVA. It's a great platform to continuously engage in continuous education, learn about other organizations, learn about what other sectors are doing, what other type of work is being done across the province, across the country. So this is a great platform, and also engage with continuing education and training with CASA. So again, we don't have enough time in this segment to go through all the nitty-gritty details that you might all have questions about, but we are always here for continuous professional development and training. Right. So we're going to go into self-care and what is the impact on service providers? How are you taking care of yourself? So taking care of yourself when supporting others. So this is a term that most of you probably heard is burnout. And unfortunately, a lot of you may have felt it before at different points in your life is burnout. I know I definitely feel it at different points for various reasons. But burnout is a stress and frustration caused by the workplace, possible in any occupation, simpler to address than secondary trauma, And burnout is not, and we're going to talk about secondary trauma as well, but burnout is not damaging to our worldview and the primary cause of empathic strain. So again, we're going to talk about secondary trauma and how secondary trauma, vicarious trauma can damage our worldview and cause things like empathic strain. But burnout is, you know what, it's been a tough, first 5 months of the year. A lot has happened. A lot has moved quick. A lot of different tasks has happened. I'm at the end of my leash. I need to take a vacation. I need to use my health and wellness time. I need to, reel it back a little bit. I need to leave work at work sometimes, or a lot of time. Actually, most of the time you should do that, or all the time if that's possible. Leave work at work. So it's the stress and frustration that caused by the workplace, whether it be workload, conflicts in the workplace, changing organization structures. Unfortunately, we're in a time where like things like layoffs are becoming more common and all of that kind of stuff. So even the anxiety around things like that can cause burnout, decision making, decision fatigue, not feeling supported by leadership or your management, not feeling heard, taking on other people's workloads, things like that can cause burnout. So stress and frustration caused by the workplace, and it's possible in every occupation. So whether you are in finance or you work at CASA, burnouts is across the board. So we're going to talk about secondary and vicarious trauma. So this one describes the profound shift in worldview that occurs in helping professionals when they work with individuals who have experienced trauma. So highlighting helping professionals, so that can include teachers, human and social services workers, healthcare workers, police, all of those things. So very, very direct human facing professionals. And happens because they are working continuously with people who have experienced trauma almost on a daily basis, if not a daily basis. Helpers notice that their fundamental beliefs about the world are altered and possibly damaged by repeatedly exposed to traumatic material. Again, it is beyond burnouts. This is not just like, oh, I have a heavy workload this month. It's more so that I am seeing almost a worst of human suffering almost every day from my life for 40 hours a week or more. This is impacting how I see myself and how I see the world around me. So it's quite deep, and it affects, again, your worldview. It's a shift, it's a paradigm shift. And it goes into a place that, you can have compassion fatigue or things like empathic strain. So these are some ways to recognize secondary traumatic stress within you or people around you. This is also a good way to check in, maybe with a coworker or a friend that you know is an EMT or a firefighter. So this is another thing you can use to also check on your loved one and people that you hold near and dear into your heart. So number one is exhaustion, insomnia, headaches, increased accessibility to illness, sore back and sore neck, irritable bowels and DI distress, rashes and breakout, grinding your teeth at night, heart palpitation, and hypochondria. So, yes, these are some ways it can physically manifest. I don't know if you folks have read the book, The Body Keeps Score, but the body keeps score and it wreaks havoc when you're not paying attention and can manifest in so many things. Another thing you can do is oversleep, hypersomnia, have trouble with your appetite as well, eating, drinking, sleeping, like all of those things. Again, it could be a manifestation of secondary traumatic stress. Next is behavioral, is increase in the use of alcohol and drugs, anger and irritability at home and at work, avoidance of clients and patients, watches such amounts of shows, Netflix, doom scrolling on social media, just scrolling through all the TikToks and the Instagrams and the Facebook posts, just doom scrolling, feeling helpless when hearing difficult client stories. So you're feeling like, oh, wow, I'm supposed to be the professional in the building and offer you resources and support, but I feel very helpless. I don't know what to do. I don't know what to do with this information. I don't know how to support you. Next is problems in personal relationships. So this can be familial, romantic, platonic, co-worker relationships as well, so some behavioral manifestations. Next is engaging in frequent and negative gossiping and venting at work. So this is another one to highlight. Sometimes, yeah, it could be like, the workplace is giving you a lot of stress and, you're having conflicts with person A, or because of the secondary traumatic stress, it can veer into the place of you're trying to get this out because you're trying to manage your internal trauma, and it's coming out in the place of gossiping and venting at work in a way that can be also quite counterproductive and potentially harmful to you at work. Next is impaired appetite or binge eating. So again, a little bit of physical and behavioral. And that last category is difficulty sleeping, nightmares, feeling hopelessness, emotional exhaustion, depression, guilt, depersonalization. So this is spacing out at work, right? Sometimes when you drive, and I'm gonna admit to this, sometimes when I'm done at work, done at the office, I know I get in the car, I know I turn it on, I know like I'm driving, I know I'm driving, but I'm not there. Like it's almost I should have like an auto driving car at that point that just got me from point A to point B, but I know I'm not actively engaged in the process of driving, even though I'm physically in the driver's seats, hands on 10 and 2, foot on the accelerator and the brake, but I'm spacing out through the whole process of driving. Next is disruption of worldview, heightened anxiety or irrational fears. Next is difficulty separating personal and professional lives. So again, decompartmentalizing. I know we all strive, or most of us strive for workplace balance, work-life balance, and you feel like you can't do that, right? It's not like you just don't. It's not because you just don't have enough time off of work, like you don't have enough hours to take off of work, or all that kind of stuff, or they're working longer days. It's like everything is now meshed together. Work is home, home is work, and that is a place of for sure checking in. Next is intrusive imagery, and next is feeling responsible for clients. And this is beyond your professional responsibility, but now it's getting into the very crossing boundaries, and this can go into potentially harmful territory in terms of your own psychological well-being. And again, crossing boundaries, whether it's patient boundaries, client boundary, you want to community members boundaries, you're going above and beyond in a way that is not just you being a good person, but is again, you're feeling too responsible. You've overly personalized that relationship with a client or a patient. So, empathic strain, the less ability to hold compassion over time because of repeated exposure to overwhelming traumatic events. Or traumatic material. So, anybody that works in healthcare, social services, human services, all of those things, policing, firefighters, all of that world, this is something that we should always be attuned to and know this is quite possible just because of the nature of the work. I've heard it once said that this is an occupational hazard, and I like to kind of reframe it more than just an occupational hazard. You signed up for it. Like if you're an ICU nurse or an ER nurse, of course you expect to see, very, very traumatic stuff. But it's not a way of you can't take away the nature of the work that is your job description or that's part of the job, but we can humanize our responses to people who work in these type of environments and know that again they're being exposed to traumatic material every day. For a lot of people on the hourly basis, you're hearing very, 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 or seeing very, very traumatic things or responding to very, very traumatic material. So again, it lessens our ability to hold compassion over time. So people know as compassion fatigue that sometimes you just check out and you just have that flatness, coldness. Is that I'm here to get a job done. You can see, the most horrific thing and just hold that flatness. It almost feels like that loss of why you got in, that passion, that love of humanity, that love to want to care for humanity has left because again, you're just seeing this over and over again. And your ability to hold compassion over time decreases. So I'm gonna peek at my time, and I think I have a couple or more minutes left in the segment. So just to be aware of time, I'm just gonna go through these last slides. So protective factors and resilience, compassion satisfaction. So are you okay with where your compassion is? Are you okay with your network of compassion where you can lean into to get that compassion and feel that compassion again, to feel again, right? Especially when you've reached that level of empathic strain. So where is that for you? Next is continuing professional development. So platforms like AVA, CASA has our training, resource, and education program. Other places have amazing education, online, in person, 1 hour lunch and learns, 12-week courses. There's so many ways you can engage in professional development to build that resilience, build your capacity, and build your professional scope. Next is supportive professional networks, right? We have, again, I wouldn't in the slot AVA here as a professional network of sorts. Yeah, so get to know people within your industry, within your sector and outside. Again, collaboration and mutuality and exchange of knowledge, resources, and collaboration, mutual coordinated efforts to address a singular issue. And lastly, is structural accommodations. By law, your workplace has accommodations they can allow. So check into what that is. Check into what you need, especially in your workplace, and what is feasible. Again, how a doctor's office looks is a little bit, and how it can operate is different from, just a general office. So if it's possible, maybe it's an office plan. That's something you can easily put in, or you have to get more formalized accommodation. So check into with your HR policy, your personnel manuals, your administration team, and see what's feasible. So to keep you away from the empathic strain, to burnout, and to create that sustainability in your work so you can do great work for the people you serve and support on a daily basis. Strategies you can implement is develop early warning signs of symptoms. So really checking with yourself and your body. So some people, it might really be the GI stuff. You notice like indigestion, you're burping more, heartburn, you're having problems, passing stool, digesting food. It could be what you ate, and it could be food poisoning, or it could be a manifestation of stress in the workplace over a very long time, and over constant exposure to trauma in that way. So really know yourself, how your body and how stress behaviorally, physically, socially shows up for you, and know, okay, it's time for me to check in. And even with your loved ones, like, whether it's your partner, a close friend, or a good colleague, you can say like, okay, sometimes when I'm getting a little anxious and overwhelmed, I tend to do this. And if you start noticing this in me, can you, like, in love, tap me on the shoulder and let me know, okay, maybe it's time to slow down. So you can also loop in your network of support to help you do that. Next is engage in self-care. Whatever self-care looks for you, please do that for you. And also self-care is just doing the daily things, the most mundane things, like making your bed, showering, brushing your teeth, grooming, hygiene, paying your bills, taking your dog out. So the most mundane things can be the most powerful forms of self-care. Next is accessing supervision in the workplace. Next is adjustments to work. So adjusting in different ways. So you can adjust your personal life, your work life, adjustments that can be made in the workplace. So formal accommodations, getting implants. If they allow you to have a fish, maybe you can get a work pet as a fish, or some kind of thing. Maybe your office place allows you to bring in pets into work. Maybe explore what that process is and how you can bring your fur baby into work. But really ask what can be done. And if you never ask, nothing will ever be done. Again, you have to make the first step to ask your workplace what can be done and what can be honored in the workplace. Continue education and personal development, and acknowledging and addressing the impacts. Just knowing that this work every day in ways that are so little that we don't see in the short period of times, but over long times we feel. But there are things that are impacting us on a day-to-day. And again, death by 1,000 cuts, right, is a thing, right? It's those little things, the little things you just shrug off. You're like, oh, I'll push it to tomorrow. It's not that big of a deal. You kind of undermine the impacts, but over time, when it's left unaddressed, it can lead to things like burnout and empathic strain, which are harder things to, get the appropriate support for when it's gone that far. So low impact debriefing, this is a way you can talk to your supervisor or your colleagues. So the main thing about low impact debriefing is first confidentiality of your patients and clients. So we're not telling any things that will breach anybody's confidentiality. And the four components of low impact debriefing is self-awareness, know where you are at. Are you super activated by that client or patient interaction that you're still bubbling over? You're very dysregulated, or is something happening at home that's also intersecting with this client interaction? So do a self scan and say, okay, I had this interaction with this patient, this client. This made me feel terrible, icky, angry, upset, whatever that feeling is, triggered. What's all happening, not just in that interaction with the clients, but holistically for me, what's also happening at work, what's also happening at home, what's happening with my health, right? Did I sleep well last night? Did I drink water today? Did I eat that snack? Those things can also really frame and position you to do the next step, which is go into the low impact debriefing. So next is fair warning. So if you pull a colleague aside and say, and just start, saying that what happened with that very traumatic event that happened to a patient or client, that's not fair warning and that's not consent. Best way to do it is like, hey, can I talk to you? I just had a really troubling experience with this with a patient I saw. I just need to debrief. There's going to be some things that can be potentially graphic about the story. So I'm going to give you some time to, let me know if you're in the headspace to have this conversation with me. Maybe we can step outside. Maybe we can go for a walk around the building while we talk about this, or all that kind of stuff. So allow that person to also consent and check their own capacity as a person that's hearing the story, and potential will support you as a colleague or a supervisor or a manager. Next is limited disclosures. So again, we're keeping out unnecessary details. We don't have to go into the graphic nature of it. Even saying something like sexual violence, you don't have to go to the nature of the sexual violence that was experienced. So really limiting the information for confidentiality reasons, and for B, we don't want to also pass that trauma to another person. We don't want to destabilize that person. That person is coming as a support person to support you in the best way that they can. So we want to limit traumatic exposure across the board the best way we can. So these are CASA's key messages: is I believe you. It's not your fault. Your feelings are valid. Your needs come first, and I support your decision. So these are our key messages, and this is what we want you to integrate into your personal and professional lives. And these key messages can be transferable in any kind of situation where we're supporting someone who has experienced sexual violence. So it's always fundamental to know that, let that person know that they are believed. It's not their fault. Your feelings are valid. Your needs come first, and then support your decision. Again, transferable. And the most important thing I've been telling people, I guess for years at this point, is that the reason that they're telling you first is because they want that humanity. We don't want this to be like a rehearsed script that you went and scripted it out and you're saying the perfect things. Is the perfection of supporting disclosures comes from that human interaction, that active listening, that on eye contact, on honoring people's boundaries with physical touch, showing that you're there, you're really listening, you see this as important, and again, you believe them. So that human interaction is super important, and find ways to say this in your own language, in your own words, to best support that person. But these are this is the essence of what we want you to show the people that you are supporting. So healing is possible, but it is not linear. It can be a lot of this. It can go like this, and then for years, and then it can shoot up again. It can shoot down. But it is possible. It is possible, and people are resilient. People who have experienced sexual violence are very, very resilient. Some of the most resilient people that than I know. Unfortunately, with how common sexual violence and the impacts and the experiences of sexual violence is, we know way more people that have been resilient and powerful through their journey. So honor that and know that people are resilient, and healing is always possible. So about CASA, again, we are the primary sexual violence agency in Calgary and surrounding areas, and we have been in operation for over 30 years. So our vision is healthy communities free of sexual violence, including sexual abuse, sexual assault, and sexual harassment. So we lead specialized services in sexual violence. So I say anything that happens in Calgary and surrounding areas around sexual violence essentially comes some ways funnels back to CASA. So our main services is our support and information line. So essentially this is it operates as a crisis line, but this is also a line that you can use for consultation, learning about more about the referral process. We do intakes on that line, so that line serves as a hub for everything. So you can call that line from 9 to 5 p.m. Monday to Friday if you want to talk to a CASA staff, and on the weekends from 9 to 9, and all the holidays and weekday evenings from 5 to 9 p.m. It's operated by our team of lovely volunteers so we can keep that line operational 365 days a year from 9 to 9 every single day. So it's a full line, including resourcing as well that happens on that line. We have our public education, essentially what you engage with today. And our public education is lifespan education. So we have licensed curriculum called Who Do You Tell that goes as young as preschool. So we're going to the littles, the 3 and 4-year-olds talking about like body autonomy, safe people, safe and unsafe touches in a developmentally appropriate level. And then we have our Birch Grove program that deals with middle school age kids and high school age kids as well. And then we have our adult education that includes community education, professional education, workplace education, and all of those things. So we address sexual violence education training at any age and throughout any community and demographic. Next is our community outreach. We're constantly engaging with the community. We want the community to engage with us. So we're looking for ways to collaborate, partner, and really lead a community-led response and approach to sexual violence education and support. Next is our police and court education program. Police and Court Education and Support Program. So this is a team of our lovely counselors who guide and support and educate clients who are engaging in the court process. So this is from the pre-contemplative reporting. They don't know if they want to report, they want to get more information, they want support through that process, through the reporting stage, into trial, and also after trial. So they go through every stage of support through the police process and the reporting process and the legal process with our clients. And it's an amazing program. Next is our sexual response team. So that is in collaboration with AHS. This is an interdisciplinary team. We are a mobile team. We go to any hospital and urgent care area sites in Calgary, except for the Children's Hospital. They have their own internal team. But we do have a dedicated unit in the Sheldon Schumer, which is an urgent care in downtown Calgary. But we are a mobile team composed of doctors, nurses, and CASA staff. And we have the ability to liaise the police as well and start that process with policing as well if the client and the patient chooses that that's what they want to do. And going back to choice, we have the third option where we can store forensic evidence from a sexual assault kit for up to a year while a patient decides if reporting is best for them. So we lay out all their options, right? We don't say you have to report or you have to take a sexual assault kit. You don't have to do anything. You can just come there and say, this is what feels safest to me in this moment. And then we will accommodate that and get that rolling for the patient. And this service is for people who have experienced sexual assault. So up to 7 days post the sexual assault they experience, they can access this care. And we have it at 7 days. It's limited in time because, in the instance of a sexual assault case and collecting forensic evidence, that's time sensitive material that we need to collect. So that is an amazing program as well. We have individual and group counseling. We have up to 24 free sessions for someone that has experienced sexual violence and up to 6 free sessions for the loved ones of the people who have experienced sexual violence. We also offer group counseling options. And then we have an integrated case management. So for folks who are not yet fit or ready for counseling, we don't want to just leave them and say, oh, come back when you are, more counseling ready or more counseling fit. So we help them with system navigation, housing, resourcing, their basic fundamental needs. We really want to keep them connected and resourced and supported, even if they're not counseling ready or if they are engaging in counseling or our police and court program. This is just an additional layer of support that we provide the community. And lastly, it's our volunteer engagement program. We can't do all this work by ourselves. Absolutely not. They help us in our line, boothing, and other different events that we have for CASA. So they're integral and fundamental to the work we do here at CASA. So CASA, again, we are a very wraparound sexual violence support organization. And we're also here for professionals. So if you have questions about a patient and client, about the referral process, how to get in touch with CASA, debriefing, anything for you as well as professionals, you can also contact us as well. So this is a little bit of a deeper dive into the referral process. So the major takeaway is we do self-referral. So you cannot fax your patient's charts to us and just do a direct referral that way. No, the patient has to, they themselves, you can also be in the room if they consent to it, to support them, but the patient has to call CASA themselves and identify that they want it and not have like a professional in between liaising that process. So it's a self-referral. We provide clear options and information about services, emphasize trauma-informed care and client empowerment. Confidentiality and client consent. CASA does not release the records without explicit client permissions. All information is shared only with the client's full consent. We ensure clients are fully informed about the consulting process, and no specific information is shared without a release of information form, so ROI on both ends. So we are very thorough and tight with our documentation, consent, and paperwork and approval from our clients. Next, we have dedicated intake workers. So we have clients first complete the intake, and this process determines if they need an additional consultation with external professionals. So if you are working with them as a doctor, through that intake process, we'll determine next if we need to bring the doctor back into how we navigate that particular client's needs. Next is consultations with professional support if needed. Following the intake, CASA staff may consult with the client's professional support to evaluate service fit or to ensure continuity of care. Next is general professional inquiries. Professionals can call CASA to discuss general service fits without sharing specific client information. Again, confidentiality and client autonomy. We don't share specific client information. You can call and say, very generally speak very broadly, and we can see how we can help you navigate that. When making such inquiries, professionals should ask for a counseling supervisor. So we have our counseling supervisors to help you through that process. Next is safety and stabilization focus. So we use the triphasic approach in our clinical services. So the first goal of CASA's clinical services is to provide safety and stabilization. So again, going back to are they fit for the services? Are they ready? Is based on the safety and stabilization aspect of the triphasic approach. Yes, we also talked about the release of information. So I've been saying, is someone a fit? Is someone a fit? What does that really mean? So client readiness for therapy. So this is questions as a professional you should ask yourself when you're even thinking about suggesting CASA to a client. Does the client have enough stabilization to engage in sexual violence therapy? So this is trauma therapy. And trauma therapy, as I like to say, can be very raw. And if someone is not stabilized, again, with things like addiction or the nature of their mental health, something as deep and raw as trauma therapy can throw them deeper and exacerbate any other existing concerns, especially around existing mental health concerns or substance and addiction. So again, key considerations for service fit is mental health, so moderate to severe mental health concerns, including active psychosis or very high suicidal ideation or self-harm or severe dissociation. So ask yourself as a professional, is this client in that realm? Is it moderate to severe mental health concerns? Next is substance abuse and addictions. Are clients in the pre-contemplative stage in moderate to severe active addiction or unable to attend a session sober? May need stabilization before engaging in CASA services. So we want to make sure things like addiction, they are again stabilized before engaging in this service, because again, it can exacerbate and really throw it over the edge if they're not in a space of stabilization. And in the bottom, something to ask yourself as a professional is sexual violence the primary presenting concern? Does the client want to engage in sexual violence specific services? right? Because sometimes, again, going back to intersectionality, they might have experienced sexual violence, even recent sexual violence, but their primary need is housing or food. So again, even though sexual violence is a major contributing factor, is that really the primary presenting concern at this time? So again, we really want to have a good holistic way of looking at the issue of sexual violence as an issue and also how we best support them as professionals in the space. Okay. We have reached the end of this presentation. I would like to thank you all so much for engaging in this.
So we'll go ahead and wrap up the webinar today. And I just wanted to say on behalf of AVA and myself, Femi, thank you. I so appreciated this today. And overall, I truly appreciate CASA's work in general that you've shared with us over the last 4 weeks. So thank you very much.
Thank you. It's been a pleasure.
Thanks for joining us on the Her Health podcast, transforming health for women and girls at risk. Remember, your health matters, and together we can make a difference. Until next time, remember to prioritize your health and well-being. For more resources and support on issues affecting girls, women, and gender-diverse people, visit our website at avatraining.ca. This is Dr. Nicole Letourneau. Thank you for listening.